Thank you for the opportunity to speak today to GLC. This is going to be a bit about vaccine development and then a few thoughts in the end about safe learning. And I'd be very interested in hearing your thoughts because having two daughters and university in the United States has made us think very clearly and I think a lot more about this question than we should normally do. So from 180 candidates that we have in the pipeline for COVID-19 vaccine development, we're actually getting very close. And I think everyone knows that the Pfizer-BioNTech vaccine is now thought to have an efficacy of 95%, the Moderna vaccine 94.5%, and the Gamaleya vaccine from Russia 92%. You can see a list of the vaccines in trials, in human clinical trials at the bottom left-hand portion of the screen. This is from the New York Times. Actually, it's updated every day. And it shows probably about between 50 and 54, depending on who's counting and how you count the different vaccines in various stages of human clinical trials, from phase 1, where we look at safety, to phase 3, where we look at safety and efficacy. But what do we really have to go on? And when you're a vaccine developer, a lot of times we look for the simple things. And the simplest thing that we often think of when we work with viruses is something called a neutralizing antibody titer. And that is the level of antibody that is found after vaccination. And antibody, of course, is protein that binds to and inactivates viruses. And so you might imagine that the higher the level of induced neutralizing antibody, the better we think the vaccine may be a priori. And you can actually break down the 10 or so candidates that are in phase 3, the final stage of testing, by their level of neutralizing antibody. There are 3 with titers under 100, and that would be CanSino, Sinovac, and Gamaleya. We have several with titers of between 100 and 500, including Johnson & Johnson, Sinopharm, which is a Chinese company, AstraZeneca, and Pfizer-BioNTech. And then 2 with titers greater than 1,000. That includes Moderna and Novavax. And of course, vaccine efficacy was 94% with Moderna, 92% for Gamaleya, and the big, actually, what happened to my Pfizer? There we go. Vaccine efficacy was greater than 90%. Actually, now Pfizer's corrected that and said that the vaccine efficacy is 95%. But the real question here is, what's the efficacy beyond 2 to 3 months? Because these data are based on 2 months worth of follow-up. And the safety data now required by the US FDA in order to be granted emergency use approval is 2 months. So it's similar. But really, we want vaccines that protect us for more than 2 months. And it's likely that these will continue to show protection at 6 months and at 12 months, or maybe even at 24 months. But at this point, we really don't know. And we really haven't had enough time to even give you an estimate, really, of the rate of decay of the level of that neutralizing antibody. So you can imagine when you get a vaccine, the body makes a defensive or immune response against it, and that immune response decreases over time as we can measure it in the blood. Now, luckily for us, the immune system has something called memory. And immune memory is actually very powerful, and it allows us to respond to things in our, as we get older, that we've been exposed to when we were younger. And so immune memory is very important in protecting us against pathogens. We don't know how that will work with regard to the coronaviruses. And there's some thought that if the coronavirus vaccines are like seasonal coronaviruses, then the levels of antibody may decrease very rapidly and actually may become ineffective in protecting us against subsequent infection. But again, we don't really know that. The one caveat to this part of the discussion is that these assays were not standardized. So each company did its own set of assays. And what we would really like to do from a scientific perspective is really to have blood from all of the vaccine trials and to compare them side by side in the same laboratory using a highly reproducible assay that can be replicated in other labs around the world. We haven't gotten there yet. The second piece of evidence that we often will cite is protection of animals against infection. So you take an animal, and in this case, monkeys, ferrets, transgenic mice, Syrian golden hamsters, and actually special kinds of mice and transgenic mice. And we vaccinate them, and then we wait a month or so and we challenge them. And if the vaccine prevents disease or infection, then we feel comfortable that it may work in humans. But the caveat here is, Dr. David Weiner, a colleague from the University of Pennsylvania and the Wistar, says, mice lie, Monkeys exaggerate, only humans tell the truth, which will mean that the data we're seeing now from the human clinical trials is actually critically important in informing the way we think. So important proofs of concept here: Moderna and Pfizer, RNA vaccines, the first time RNA vaccines have been shown to protect humans against infection. And then the three of these vaccines, all in the same week, have been an important proof of concept that a vaccine can protect against COVID-19 infection. So maybe, as Churchill said, this is not the end or the beginning of the end, this is the end of the beginning. And that may be the best way to think about this. Because what we really need to do is think about the day after efficacy is announced. Proving it was one thing. And we have interim data now for 3 vaccines, and probably in the next week to 4 weeks, we will see at least 2 more companies, maybe 3, announce data. But really, the big question is, can we make enough of these vaccines to provide 16 billion doses? That is to vaccinate everybody on the planet. And in terms of using it, how are we going to allocate this? How are we going to distribute it logistically? How are we going to maintain the cold chain? I mean, vaccines like ice cream have to be shipped at a certain temperature, and keeping a vaccine out of temperature can actually cause it to malfunction or have lower potency than we expect. I did a clinical trial in Thailand, and it wasn't actually an excursion above 8 degrees. It was an excursion below 2 degrees, 1 degree below temperature for 8 hours, and there was a gel at the bottom of the vaccine tube, which meant that we had to discard all of them. So again, vaccines can be very sensitive to shipment temperatures. And then how are we going to administer the vaccine? And we'll get back to this. It gets to the point that vaccines themselves don't save lives, vaccination saves lives. So how to make enough vaccine? The Coalition for Epidemic Preparedness Innovation, CEPI, believes that we have the global capacity to manufacture 2 to 4 billion doses of COVID-19 vaccine per year. Now, with 16 billion doses, you can imagine that will take a long time to vaccinate everybody, to make enough vaccine to vaccinate everybody. So the models that CEPI has done predict that we won't probably have enough vaccine doses until the end of 2023 or 2024. Operation Warpspeed, which is the US program, is manufacturing over 300 million doses at risk. That is, at that time, they didn't know that the Pfizer vaccine would work or that the Moderna vaccine would work, but they went ahead and started manufacturing anyway. With the idea being that if one of them was shown to work, then the US would have ready access to vaccine supply to at least vaccinate people in the highest risk groups or people whose jobs require that they be available and healthy, such as healthcare workers. And then I think probably one of the silver linings from the COVID pandemic, if there are any, is that some of these big manufacturers like Pfizer, like Johnson & Johnson, are going to other manufacturers around the world to get increased quantity of high quality vaccines. So Johnson & Johnson, for instance, has gone to Biological E, an Indian vaccine manufacturer. AstraZeneca has gone to SK Bioscience, which is a South Korean manufacturer. So again, they've licensed out these vaccines in order to increase production around the world. Now, getting to the use of the vaccines, we have this thing called COVAX. And COVAX is actually an effort led by WHO, Gavi, and CEPI. And what they intend to do is to have 2 billion doses of vaccine available by the end of 2021. This corresponds to roughly 20% of global need. And it would be provided free or at very, very reduced cost to 92 countries, low and middle income countries. So COVAX is actually a brilliant concept. And it's really one of the first times that the world has gotten together to offer to low and middle income countries access to the same innovation that we have in high income countries. Really a remarkable thing. And hopefully this is something that we learn from and build on as we introduce new vaccines that are going to be important for global health. So COVAX is very important. 192 countries, or actually I think 186 countries have signed up, and a significant number of the contracts that need to be in place in order to make COVAX work are signed. And actually, finally, last week, they got the final tranche of funding. So they actually have now the first $2 billion worth of funding, which is what they wanted. So fingers crossed. This is a very important effort and unprecedented. The problem here is that the high-income countries have also purchased or pre-ordered vaccine. In fact, 8.8 billion doses of vaccine. So if you think that most of these vaccines are 2-dose regimens, that's actually far in excess of what they actually need. And who's going to get vaccine first is a really important question. And so despite COVAX, countries are hedging their bets and securing their own vaccine supply. And modeling would suggest that if the high-income countries take the first 2 billion doses without any consideration of equity, global COVID deaths will double, and our ability to rapidly and effectively control the pandemic will be impaired. And these are data you can actually log on to the Duke Global Health Innovation Center, and these data are available, actually a significantly larger number of slides. So final thoughts. We have perhaps 2 vaccines showing efficacy, and we'll have more by 2021. But what more needs to be done? We have to manufacture the vaccine, we have to distribute it, we have to provide some access and equity in allocation. Then there are big scientific questions. We haven't been able to optimize the vaccine. We don't know what immune responses correlate with protection. And importantly, we don't really have any real-world evidence. I mean, these clinical trials are massive undertakings that look very specifically at protection of an individual, but we are actually concerned about protection of populations. And as we think about schools, schools are a population, and a population that need to be protected. So will these vaccines that are highly efficacious also have high degrees of effectiveness? The warning here, measles vaccine, efficacy 95%. You have to vaccinate 90% of the population to achieve herd immunity. And so that is the big question. Long-term follow-up for safety, opposition to vaccination, all very important questions. So remember, the vaccine is just a weapon in the war against COVID, but you still need to have a strategy and an army to fight and win. So reopening the universities. So this is, I'm using the United States data because I read the New York Times. But these are universities in the United States, 1,600 institutions. And what you see here are a number of cases reported at these different universities. So the purple dots are actually the ones that have really, really significant numbers of cases. And actually, you can log on to the New York Times website where this is actually much more clearly seen. There have been over 250,000 infections in US colleges and universities. And sometimes, colleges that had planned really well and prepared really well, like Gettysburg College in Pennsylvania, have outbreaks, and they're unavoidable. One of my daughters goes to a small liberal arts college, and they've had 3 infections, but they're being tested twice a week, and only the freshmen are there. So it's dedensification, I think is the word that they use officially, because they don't have everybody there. It's important to realize that if the pandemic is out of control in the towns surrounding the university, it's going to be very hard for the university to control things, and vice versa. Then campus culture matters. These, some of the colleges had kids who were doing exposure parties, trying to get infected. We have, unregulated fraternities, socialization at fraternities and big parties. Teams and team sports appear to be, centers of transmission sometimes. A bit of this, unfortunately, in the United States anyway, relates to the politics of the states that these institutions are in. And a number of universities that opened are switching to online courses or canceled sporting events because of surging cases. And again, everything that we've done sometimes is not enough. So with anticipated widespread availability of vaccines for COVID-19 in the middle of next year, it might be too late for classes in January to June. In the US, with the vaccine mandates, with a vaccine mandate in place, so that in order to come to school, you need to be vaccinated, similar to what we do for school children in elementary school. It may be easier to reopen classes in the fall of 2021, depending on the success of rollout and the availability of vaccines for use. In other parts of the world, the timing of vaccine availability and prioritization and vaccination requirements may be really critical in determining the impact of these vaccines on the ability of classes and schools to function as they normally do with face-to-face instruction. The effectiveness question, this question of herd immunity, does it definitely apply to schools, and it's very critical information. But in the meantime, and even as vaccination campaigns are being rolled out, we have to remember that masks are going to be important. Distancing will be important. Dedensification and hand hygiene are still going to need to be maintained as vaccination progresses through the population. The final point that I want to make here is around science education, because the culture of disbelief around science is profound and has, at least in the United States, had dramatic negative implications for our ability to convince people that vaccines actually do a remarkably good job and are remarkably safe. And it turns out that the United States isn't the only country where there's where there's disbelief in the safety and efficacy of vaccines. So that's the last slide, and thank you.
Thank you, Dr. Kim. Thank you so much. This has been a very sobering presentation for me, I have to say, after the jubilation with the great efficacy results announced in the last 10 days. And thank you for showing that this is just tip of the iceberg.
But it's an important weapon to have, these vaccines. Better to have it than not. And it gives us a way forward, which we didn't necessarily have before. So some cause for celebration still.
Yeah, thank you for putting everything in perspective. I would like to open the floor for questions.
Yeah, if I may jump in, please. Yep.
Yes.
Yes, please go ahead, everyone.
Thank you, Dr. Kim, and greetings from Hong Kong, from the Hong Kong University of Science and Technology. Your presentation was very informative, and I learned a lot from it, so thank you for that. I am personally a consumer psychologist, and so I'm totally on board with your idea that people don't always do what's best for them, people counter-argue, and so the fact that just having a vaccine is the first step resonates a lot with me. But I would like to ask you a more personal question, which is, you're a scientist who knows everything, about the vaccine and about, knows a lot, obviously, about, the safety ramifications of this disease and so on. Yet you've made a personal decision, and your children are at a university in a country where the pandemic is out of control. And as educators, we have to cope, with situations where parents are making decisions and people are making decisions for themselves. It might be preferable to not have students on campus because that's just safer. And there's a whole lot of other logistical issues to have to contend with if people stayed away. But there's a strong preference also for people to be on campus. So how would you communicate that, to parents such as yourself? What's the best way to communicate this particular trade-off?
So that's a really great question. My older daughter is actually learning at home. Her school is in California, which had until recently been doing a better job than some states, but with the surge, everyone's at risk. The younger daughter is in again, small school, and the school decided to only allow the freshmen to come for the first semester. And then depending on how the freshmen did, to allow the seniors to come in the second semester so that they could graduate. And, with twice weekly testing, with organization into pods, the normal dormitories are less than 50% capacity. So in what would normally be a suite that holds 4 people, there are only 2. And so they've really done everything to try to limit exposure. That being, and from the beginning where they admitted kids and people were in quarantine for 2 weeks, they had 2 cases then, and they were brought in from the outside. From then until last week, they had no cases, which again, very responsible. They explain that we get a weekly update from the president. Very, very, very good. And of course, there was a break. As in Korea, right? In Korea, everyone wears a mask until they're not wearing a mask. And it was a member of a team. They went out and had a party with people from the outside. Of course, the state is having a surge. And now 2 team members are infected and 16 people are in quarantine. But they had thought through the response. They were doing frequent testing. They think that they picked it up. They're doing the appropriate thing in isolating individuals. It's more difficult on a campus with 40,000 people. Although some of the larger schools have done relatively well, I think that the problem with COVID-19 is that we get lulled into a sense of security. Sweden looked like it was doing better again, and then all of a sudden, the wrong set of infections happens and you have another surge. Korea was under 50 cases for over a month, and then there was an outbreak in a large church. Over 50% of the church members became positive. And that just spread it all over the country, because with 1,000-something infections with people from all over the country and with families and get-togethers, it became much more difficult to control. So I think it's an individual assessment of risk. We have worked, because our children have lived in Korea before going back to the States. They're very familiar with the rules around wearing masks and staying safe. And we got sent pictures back from, when they've gone out to go and, eat. And the pictures are all of them in their masks. Maybe they're just doing that for their parents, but it's important. I think as a consumer psychologist, it's really critical. I mean, how we get people to think about this, whether it's getting, it may not work to order people in the United States to wear a mask. I mean, probably won't. But if you start to frame it in the sense that, it's not, what you're doing is you're wearing the mask because you care about the other people you know and talk to. And you encourage them to participate. And, there are all these different things that are short of, the old, this is your brain on drugs, that may not work as well anymore. And anyway, but it'd be really fascinating to get your perspective on this, because working with kids who are 18 to 30, or kids who are, late teens and early 20s, they have this sense of invulnerability. They think that this is not going to affect them much, and that may be true. On the one hand, what they forget is that they interact with their parents and their grandparents, with people in the community, and they forget that this is about the other people.
Thank you very much. Yes, I completely agree with you that and it's also a social thing. Different societies have different levels of tolerance, so
yes.
It's very, very complex.
Atlantic had a great article on that, which I posted on the chat, which is called "America Will Sacrifice Anything for the College Experience."
For the what?
And it seems America will sacrifice anything for the college experience. And it's a very interesting article, and this is really pretty consistent with what we have seen. I'm a member of the board of Imperial College, and last night we had a session and we were discussing about enrollment. And when they offered to the students the possibility to stay at their native countries, the vast majority, 70, 80%, said no, we won't come to London. And this was pretty consistent across freshmen, and particularly freshmen were more intent to go to London rather than stay at home. So this seems to be something which is a constant. So it's an important experience, and we have to think about how we communicate and motivate these experiences and change behavior. And I think that's an element which we have underestimated.
And I think that there's a learning experience here. And again, this gets to how we teach people. How actually college should be an opportunity to do the things that they didn't learn in high school, which are probably to think more deeply around some of the issues around personal liberty and protection of others. I mean, is the theory of liberty that I can do whatever I want regardless, or is it I can do what I want as long as it's safe and doesn't endanger others? And so this gets to there are 150,000 deaths from lung cancer in the United States. And because of the risks of passive smoke, we've banned smoking in buildings. So then if you think 150,000 deaths from lung cancer every year, a portion of those, a very small portion, will be secondary smoke cancer-related deaths. And we put into place laws that prevent people from smoking in buildings. 250,000 deaths from COVID-19 in 10 months, and we can't get people to wear a mask. It's the concept here is we don't allow people to smoke in bars or in buildings to protect you against cancer. To protect you against COVID, we're going to dispute the use of a mask. But again, this gets to a very important discussion around what we consider to be important in society and how those rights and principles intersect and interact, and how we have to make logical and reasonable decisions as societies around them. We've kind of lost that in meme-driven, thoughts for the moment, 140 characters. I don't know. You've probably thought a lot more about this as educators than I have.
Gary, you've raised your hand.
Yeah, so thank you, Dr. Kim. They're very interesting. What I find interesting about the conversation, living in Australia and Queensland, our institution is still looking forward to staying online and virtual into 2021. And relative to the caseload of COVID between the countries, right, I find it interesting that there is discussions about opening up and having on-campus experiences. We've had 2 semesters or 2 trimesters now of experiencing teaching online in a virtual setting, and our institutions really adopted a stance of actually trying to get better at it, even though we may not necessarily be hit with another surge of COVID. But we've learned so much in the last 2 trimesters, we should pursue improving it. And if there were a second surge, then clearly, the disruption to the way we deliver is less of a risk. We continue delivering in a style that we think is probably a little bit more future-proof. So I do find it interesting that there are all these discussions going on about being on campus.
Actually, I have a question for you. Do you think part of that is because Australia has a history of distance learning?
I think so, but honestly, from at a ground level, the acceleration in staff adoption of technology-based learning during what was halfway through a trimester and into the second trimester of this year was phenomenal. I mean, this is like an accelerant of change. It's moving from a combustion engine to electric cars. We don't want to go backwards. I think the institution has seen that there's enough base skill level that has been learned during this period to actually truly change the way we deliver our business. And I think slipping backwards into a modality of the past is not necessarily something that we should be trying to do. We should be moving forward.
Yeah, it's interesting because listening to one particular person in our family complain about professors who, instead of delivering a lecture in 50 minutes, now go an hour and a half without regard to time. And the lack of the ability to participate in meaningful discussion because you're zooming in from wherever. And and maybe also in the United States there's a bit of a, like for instance, this particular some of the colleges have issues because some of the students, particularly scholarship students, don't have access to the internet or don't have easy access to the internet, so it makes it much more difficult for them because of inequities. Which is,
that was a big discussion we've had just before you joined us about the digital divide. That was a big thing that came both on digital divide and digital capabilities. I would like to give the floor to, I see raised hands from Professor Manand and then from Professor Sia. Professor Manand, do you want to go off mute?
Thank you. Dr. Jerome, I just have one query. It is with regard to vaccination. Is vaccination essential even for people who have recovered from COVID? And also, those who have been vaccinated in future, will they also need revaccination after some time, taking into concern of resurfacing second, third iterations?
That's a very good question, and the short answer is we don't know. There have been documented cases of reinfection, so that we know.
Hello?
Hello? Sorry? Oh, am I not?
Yeah, we can hear you. Yes.
Okay. So sorry. So the short answer is we don't know. And
you're audible.
I'm on mute?
No. We can hear you well. Dr. Kim, proceed.
Sorry.
I think Professor Manand has some challenges.
Okay. Sorry. So the short answer is we don't know. What we do know is that people have been reinfected, and so there may be cause to revaccinate people who have had documented COVID infection. Now, as you know, when we do a mass vaccination campaign, so when you think about one of the challenges of COVID, right? Globally, we've done a remarkably good job, thanks to Gavi and UNICEF and all these global agencies. We've got childhood vaccines in what the WHO calls the extended program on immunization up to the 80% range. Really a remarkable thing. So EPI has vaccinated actually the vast majority of children in this world. The problem with COVID is we need a UPI, We need a universal program of immunization because we're now going to be vaccinating those children and infants, teenagers, parents or adults, and then and the elderly. And that's going to significantly increase the burden on healthcare services throughout the world. And so when you're doing one of these large vaccination campaigns, you don't usually check if a person's been exposed to cholera before. You just give them the vaccine. And what we don't know is how those vaccines behave when they're given to a person who's already had an infection. Because there could be things that are different because the prior infection reshapes the immune response to the vaccine. And again, we just don't know. So those are some of the important questions under optimization, boosting and other things. So yes, and will we need booster doses? Many people think we will, given the current vaccines. In the future, when we have much better vaccines, maybe not. But again, right now, the thinking is we will need it, but remember that we only have 2 months worth of data.
Perfect, thank you. Jimmy.
Thank you very much. This is Jimmy Xia from Nanyang Technological University in Singapore. Thank you, Dr. Kim, for a wonderful presentation. The group over here, this is GLC, Global Learning Council, are individuals representing higher education institutions all over the world. So the question I have as a mechanical engineer is, are vaccines ethnicity specific from your experiences? Do we have the same type of vaccines for Africa, for African people? It may not be so important for a country with a relatively uniform population ethnicity, like India, like China, but that could be critical for Australia, for the United States.
You know, that is a really great question. And it gets to actually some criticisms of the Operation Warpspeed program, so that there were course adjustments made, last month even, to increase the enrollment of people from diverse backgrounds. So what they've said now is that between 30 and 40% of the people who participated, for instance, in the Pfizer trial and also now in the Moderna trial, were from more diverse backgrounds. And in fact, in the elderly, the Pfizer vaccine has 94% protective efficacy. So we often consider the elderly to be a special population because they don't respond as well to vaccines in general. Now, there are some very, very specific instances where people with certain genetic mutations don't respond to vaccines, but those are fairly uncommon. And so that the rotavirus vaccine that we use in the United States and in Singapore, in Korea, is the same as the rotavirus vaccine that's used throughout Africa and in South Asia. The issue here is that there could be differences in responses, not due to ethnicity, but because of so in the case of the rotavirus vaccine, or in the case of the oral polio vaccine, which really did a remarkably good job at eradicating polio in North America, we find that the vaccine response rates are significantly lower in sub-Saharan Africa. And the reason is that children there get a series of intestinal infections that impair the ability of the normal gut immune system to respond to the oral vaccines. And it applies to the oral cholera vaccine as well. The same issue applies. So there are geography and poverty related, presumably, conditions that impact us probably more so than the genetic differences. But again, this is, I'm generalizing over, all the different vaccines that we use, but in general, we use the same vaccines all around the world, and they've done a remarkably good job.
This is fascinating. Thank you so much.
Thank you so much. Thank you for this presentation, and which steered to this great conversation. Dr. Kim, really appreciate your input. I think it gives us a different perspective about how we should think about the future and what needs to be done. So really appreciate your input here.